All right, I'll be right back. I'm going to turn off my camera real quick.
Sounds good.
All right, we can get started in a couple minutes.
Sounds good.
All right, we can get started. Hi, everyone. Welcome back to My Medical Message. Thanks for joining us today. Today, we have Dr. Rohan Venida, and he's a family medicine resident. So welcome to My Medical Message.
Thank you. Thank you. Excited to be here. Nice to see everyone, but I don't see everyone, so it's a little weird, but it's okay. I see the messages or the questions coming in, so that's what I wasn't daydreaming. I was thinking of my answers. All right, so shall we get started?
Yep.
All right. So, as she said, my name's Rohan. I'm one of the family medicine residents. I am a resident at Beaumont, Farmington Hills here in Michigan. I live here. I've grew up here most of my life, so it's nice to stay in the area. For medical school, I went to Michigan State College of Osteopathic Medicine, so I'm a proud DO. And before that, I went to Wayne State for undergrad. So I've kind of just been here my whole life, and really grateful to be where I'm at today. I know a lot of you are on the journey, and no matter what point you're at, whether high school, undergrad, beginning years of medical school, I think it's a stressful time, but it's an exciting time. And what just the overall theme of today is just going to be to enjoy the process. Just talk to people that are ahead of you, not your friends, because your friends aren't that much more ahead of you than you are. And so when you get to talk to, it's great that you guys are here, trying to get more insight from someone who's gone through the process. I think it'll help give a lot of reassurance. Hopefully it's not scary. I don't mean it to be scary, but if it is, just let me know. So there's lots of questions coming in, so I'm just gonna try to answer a few, and then we're gonna get some cases done today, and then we can continue the question and answer session as well. So family medicine. So in medical school, I was interested in sports medicine, musculoskeletal medicine, and so I was between PM&R, which is physical medicine and rehab. It's a smaller specialty, and then family medicine. Both of them I liked. Both of them had their pros and cons in my head. And ultimately, life made the decision that, all right, we're going family medicine route. And I'm planning on doing a sports medicine fellowship after residency. So I'm in my second year right now, so I have 2 more years, just under 2 years, and then we'll be applying for a fellowship in sports medicine. I think family medicine is really unique because people usually think about it as, oh, that's in terms of salary, they don't get paid as much, and it's very simple and things like that. But after you get into the field, you start your training, you get into the last 2 years of medical school and into your residency, you realize it's so much more than that. You're the first line, doctor for anything, and family medicine is a specialty where the lines are very blurry in terms of what you're allowed to do, which is awesome because then you can do anything that you want to do. They're family medicine doctors. We just had a lecture this past Wednesday of a family medicine doctor who does C-sections. He delivers babies. He had to go through a 1-year fellowship for that, but there's doctors who do that without a fellowship. You can take a weekend, not just one weekend course if you want to do a surgery, but if you have the right experience and you have the right patient numbers, the possibilities are endless. And I think that's the really cool thing about family medicine. You can make of it what you want. You don't have to practice every aspect of medicine, even as a family practice doctor. I want to do sports medicine. It's something that I'm super passionate about. It's, some things just click better than others. When we were studying the muscles, their attachments and things like that, people really hated it, but I really loved it because it made sense to me. Muscle starts here, ends here, does this. Okay, that makes sense. It's a lot of memorization, but it's something that it has really grown on me. Being an osteopathic physician, we also learn, OMT, or osteopathic manipulative technique, which I use all the time in clinic. I have so many patients, even my co-residents, my attendings will refer their OMT patients to me. That's how much I do it. So it's a lot of fun. You get to use OMT in lots of sports injuries. You get to use it in kids. I just used it on someone who had been coming in with like fluid in the ear and these sinus symptoms. So just did some drainage techniques to help them feel better. Yeah, you give them over-the-counter medication too, but hey, if I can get someone 2 days, they're sick for 2 less days, then they're going to come back to me. They're going to like me over someone else. So, people don't like taking medications. You'll realize that. So the more tools that you have in your toolbox, I think will make you a better physician no matter what specialty you're in. I've come to respect all, the specialties, as we should as doctors, but even throughout rotations, I had a really good time, even in specialties that I knew I was never going to do, like OB or surgery. It makes you a well-rounded physician. And so the cool thing about family medicine is we get to do a little bit of each. So the options are open, and in the future, if you ever want to narrow your practice or expand your practice into doing, office procedures and injections, other things like that, the possibilities are endless. Some of these questions: family medicine, we're treating everyone, they say, from womb to tomb. And so, from delivering babies all the way till when people die, and everything in between. Pediatrics is, of course, 18 and under, with some exceptions for a little older than that. So I think that's a really cool thing about family medicine. You get that continuity of care. I really loved emergency medicine as well, but again, that's acute care, while family medicine is chronic care of chronic illnesses. And it's hard to sometimes counsel patients on that. But I think that's the skill that a family doctor needs to have, is how can I build rapport with my patient, trust in my patient, so that they do the things that I tell them to do. And I'm very blunt with my patients. I tell them, hey, you need to do this. And I say, are you just saying yes, or are you going to go home and not do anything I'm telling you? And some patients are like, yeah, doc, that's not going to work. I was like, then tell me so that we're not wasting our time. So I think that's some primary prevention, right? Like primary care needs to have primary prevention. Prevention is the name of the game. Our job as family practice doctors should be ideally to make all the other doctors go out of business. And that's not because it's a competition, but that means we're keeping people healthy. Obviously, people will still get sick, they'll get injured, life happens. But I think with that mindset, at least, we want to keep patients as healthy as possible. So, and that relates to osteopathic principles as well, right? As a DO, you guys may have heard of the 4 tenets of osteopathy. The training that you get in medical school is really based on those principles for the most part. It teaches you how to think about a patient holistically. It's not just, diagnosis, treatment. It's okay, what are the other factors that cause this diagnosis? Because, for example, mental health, depression, there's a lot of medications that you can give for depression, but are we talking about stress? Are we talking about sleep? Are we talking about childhood trauma? If those things aren't addressed, medication won't do it. And so it's not just about, we're not anti-medication. We give the same number of medications, but we also want to make sure that we get to the root cause. And ideally, every doctor should do that, right? Whether it's a DO or an MD. So it's not to say that MDs don't do that. It's that philosophy is constantly reminded to you in osteopathic school. So I think that's what the cool part about that is. My experience at MSU was amazing. I think it's a great school. It prepped me very well. We were just talking earlier, every school is going to have their quirks and things that you don't like about it. But from talking to other people, in the area at other med schools, even around the country, I was like, wow, I'm so grateful that I went to MSU. They're connected, they have base hospitals all around Michigan, so you never have to worry about, your third and fourth year rotations and things like that. So I think overall it was a great experience. If you're thinking about coming to MSU, you should. Let's see. Hope I answered a lot of these. And if there's anything, you can just let me know by unmuting yourself if there's something that you really want me to answer. Let's see. Primary care, family. So I see a few questions about primary care physician and primary care specialties and family medicine. Primary care specialties, you can think of 3 of them. It's family medicine, internal medicine, and pediatrics. Those are all primary care. Internal medicine is obviously mostly in the hospital. Family medicine is outpatient. Pediatrics, again, is outpatient or inpatient, but it's only kids, so under 18. I don't know if some people throw in EM, emergency medicine as part of that, but usually the primary care specialties are the other 3 that I mentioned. So family medicine is just one of them. Family practice can also practice in the hospital. There's so many jobs out there. There's such a shortage of every kind of doctor, but especially, primary care. So finding a job is not difficult. The class that just graduated, the 3rd years from residency that just graduated, they had to try to look for a job during COVID. So they were really scared. But still, out of the 4 of them, we have a pretty small program. 3 of them went to different states, and then 1 of them stayed here, and they didn't have any issue. They got packages that they asked for, their starting bonuses, all the fun stuff. So that's never going to be a problem in terms of scope of practice. I want to do private practice. Private practice, solo private practice is not very common nowadays. You usually want to join a private practice group. As a sports medicine doctor, I can also join an orthopedic surgery group or a physical medicine rehab group. We all work together. It's interdisciplinary management of patients, in terms of pain, sports complaints, senior citizens with arthritis, people who get into accidents. You see so many different complaints. So that's kind of what I want to do. I don't necessarily want to work within a hospital, just because hospital then dictates what you do, how much you do. You can't take certain vacation, don't want to be dictated like that. But then again, in private practice, you have to practice a little bit of business of medicine. And the general consensus is people who go into medicine because they hate business. So there's very few people who want to put up with the business side of things, staffing, things like that. But if you're down for that, private practice pays, a lot better. There's a lot more flexibility, but there's sometimes a little bit more work too. So let's see. Wow, I feel like I'm just talking a lot and there's no dialogue, but that's okay. Flexibility of the job and life balance, that is a huge reason why I narrowed it down to physical medicine and rehab and family medicine. Work-life balance is everything. When choosing a specialty, people say, oh, I really love to do this. Or, some people will pick a specialty because of the pay, which, by the way, yeah, pay is there, but it's a terrible idea. Because if you don't like what you're doing, trust me, you'll be miserable. You can't just say, oh, I'll suck it up for residency, 3-4 years, and then life will be good. Doesn't happen. And everyone who's tried, those are the people who end up dropping out of that specialty and then getting a specialty in a different residency, or different residency in a different specialty. So pay is certainly there, but again, it's not gonna matter too much. While we're on pay, you guys might we've all done it. Let's be honest. We're not doing it for the money, but let's be honest. We've all looked at the salaries for different specialties. Okay. We can't deny that. I have too. But, and you see, oh, family medicine, oh, it's only like 200, 225, whatever. And then everything else is, there's a few below that, but mostly everything. But you have to understand that that's average. And it's about how much you want to work. And that's why I bring this up in terms of balance and flexibility, right? An average, let's say, surgeon is going to be working 60 hours a week. They're going to be working nights. They're going to be working on call. Family medicine doesn't have to do any of that. We're just working 40, 45 hours a week. Now, if you're working at, in an office that allows weekends, which many offices do, you can start, seeing patients on Saturdays. Instead of ending at 5 p.m. like normal people, you can end at 6 p.m. You can see 4 to 6 extra patients every day. You can start 1 hour early in the morning. So instead of starting at 9, start at 8. Or if you start at 8, start at 7. It's not terribly early. I mean, I know for you guys it probably is, but once you get into work life, that's not terribly early. And so if you just start expanding 2 hours during the weekdays and add a Saturday, you're working now 60 hours and now your pay just went from 200. If you're going from 40 to 60, that's 1.5 times. So now instead of making 200 or 225, you're making 350. You see what I'm saying? So I hate when people, compare, oh, family, they only make that much. Yeah, because we don't want to work as much as surgeons. We go into it for a reason. And that's not to, badmouth another specialty. It's just surgeons choose that life. They love it, but for some people, medicine is their life. And for others, medicine is a part of their life. That doesn't mean that we don't like it as much. That just means that we have other things that we want to prioritize in addition to medicine, whether that's your family, your friends, your other hobbies, a different side, gig or side job, different things like that. People love to travel, and so it's about lifestyle when you're choosing your specialty. And in most specialties, you can dictate what kind of life you want to live, no matter how competitive the specialty is. But the thing is, after, training, working your butt off, 60, 80 hours a week for 4 years, surgery residency, no surgeon is going to be like, yeah, I'm just going to work 20 hours a week. Like, that's not happening. You have loans to pay. And so that's the reason it changes you. Your training changes you. And that's why it's important to pick what medical school you go to, what kind of culture they have. And that's why I said MSU is a great culture. It's not discouraging. Everyone's there to help each other. It's important when you're looking into residency programs, not just your specialty, but even within your specialty, what kind of residents are you working with? What kind of faculty are you working with? Things like that. So the work-life balance is there. It's just you get to dictate how much you want to work. That's kind of where that stands. Let's see. Technology changing my job? That's a good question. Ultrasound is really big, especially in MSK, sports ultrasound and diagnosis and treatment. So there's lots of fancy stuff. Today, I'm actually on my pulmonology rotation today. And so relating to the lungs. So there was a lady who came in with a mass, and I got to see a robotic bronchoscopy. So what that is if someone has a mass in their lungs, we want to try to get a biopsy of it. And so what they do is they do a CT scan. That CT scan, they run through a software that makes a three-dimensional image of the entire lung. And it tells you, like, when you start from the mouth and go down, you got to go, pick this branch, then this branch, then this branch, and then that's where the mass is, and you can do it. So what the robotic arm does is the attending is just sitting there like with an Xbox controller, literally controlling this camera, like going inside the mouth. And while his camera is moving, we see the camera on one side of the screen, and on the other side, we see that digital image where that scope is going. I was like, this is the coolest thing ever, So technology is changing medicine like crazy. And we don't get to see those kind of bronchoscopies very often, especially the robotic ones. My attending actually worked with the person who invented it. He was one of the first people in the country to use it. So we're very lucky to have that. Obviously, that's not my specialty, but you'll get to see all sorts of cool stuff. I'm sure you guys have heard about the Da Vinci robot, where surgeons can do robotic surgeries. You just put your finger. I've gotten to use it on a dummy, not a patient, and so it's amazing. Just however you move your hands, you're looking inside the screen. It's beautiful. So lots of cool stuff happening. But in terms of family medicine, ultrasound. Not just family medicine, most specialties, ultrasound is getting better. It's getting cheaper. They're saying the ultrasound probe is going to be the new stethoscope. Doctors will just have their phone, they'll have the ultrasound probe connected, and instead of listening with their stethoscope, they'll just put it on and they'll just see the heartbeat. It'll record heart rate, respirations, everything. So that's the direction we're heading. So that's really cool. Let's see. Surgical fellowship in family medicine. Let me just say that's not very common. That you work with OBGYN physicians, but the hospital treats you as a separate entity. You have to practice within your means. And if there's anything complicated, obviously you have to refer out to, if there's twins or triplets, we're not taking care of that. We can, but now you're risking it, then you're going to get sued. So you don't do that. You practice within your means. So you can certainly, lots of cool specialties. Look into fellowships. I mean, I know it's lots of steps ahead, but you need things to inspire you and motivate you. So let's see. Advice for upcoming physicians. Oh boy. It depends what level you're at. If you're in high school, my best advice would be take AP Bio and Chemistry, because you do not want to take the first level classes of those in undergrad. And if you're an undergrad and if you've taken them, you know what I'm talking about. Doesn't matter which college you go to. Save yourself. Forget all the other AP classes. Don't, and maintain your grades, obviously. But it's not the end of the world, if you mess up. I have failed exams. I've had to retake 2 classes that were basic science classes in undergrad. I thought it was the end of the world. And yes, Orgo was one of them. And it happens. But at the time, you're going to be like, wow, I can't even do this. Medical school is harder. It's not going to that's not true. Basic sciences suck. I personally hate them. But I love the human body. I loved anatomy, physiology, all those things. So medical school, the higher and higher in education that you go, it sounds weird and nerdy, but you'll agree with me once you get there, it's better. It's more fun to be in school, because then you're learning the things that are only applicable to you. You're not learning, I don't care what happens in a cell, like that's not my job. I ask any doctor, they don't know what happens inside a cell, but we still have to learn it. And yes, that's a course in medical school, but you get through it. It's very different from undergrad. You don't need Orgo, for medical school. But again, pre-med requirements are there to weed people out. That's what it is. It's not indicative of how good of a doctor you will be. So don't judge your value based off of that. Because if I did, then the second half of undergrad, my GPA was the exact opposite. It was around 3.8, 3.9, but I needed that because it was very low in the beginning. So to average it out, so you would think, oh, wow, you're going to take 3,000 level, 4,000 level classes. It's going to be harder, but no, it gets easier. Your grades will improve because then it's not about weeding out. It's about truly just learning. And a lot of those higher level classes are medical school classes. So for undergrad people, I would highly recommend that try to take as many medical school level classes as you can. If you can fit it into your schedule, it will just make your life a lot easier once you're in medical school. The experience that you get for volunteering, for work experience, try to make it experience, whether that's high school or undergrad, try to make it something that you will be excited to talk about in your medical school interviews. I mean, for those of you who are writing your, primary and secondary applications, you're going to have interviews coming up. You've probably already answered the question. There's stories. You have to tell a story. Two people can volunteer at the same hospital and get two completely different things out of it. And so it's about how you interpret that situation and how well you can convey it. And again, not everyone's good at it, but you practice. It's something that can be learned. But don't waste, I did this and I shouldn't have. And that's why I'm telling you to avoid this. I was the guy who, worked in the emergency department, but I was like handing out juice and snacks to like families. It's like, don't waste your time. You're not cheap labor. Just don't do that. There's nothing you're going to be able to contribute to in your interviews that's going to be convincing enough. Instead, shadow at doctors' offices, work at doctors' offices, scribe at doctor's offices or in the emergency department, even if it's part-time, even if it's once a week, even if it's once a month, that experience is going to go much further than anything else. Reach out to doctor's offices, just Google them in your area, just call their front desk and be like, hey, I'm a medical student or undergrad, medical students probably shouldn't do that. They're in medical school, but undergrad or high school, just reach out to them and a lot of them will be more than happy to take you. If you show that interest, be professional, be on time, follow directions, and you'll get there. Those are the things that are going to be worth talking about once you get further and further along. The first year, and for those of you who are in medical school, first 2 years are tough. Step one is definitely the hardest. It was the hardest thing I've ever done. That's not to scare people, but I think a lot of people would agree. It's really awesome that the USMLE now is only pass fail for step one. I mean, you can imagine that's how bad of an exam it was that even they changed it. But I think it trains you to really just have mental strength. How you're going to be pushed to the limits, and so are you able to withstand the pressure, the high stakes of the situation? And get through it. And I think that's what it's about. It's about not just learning the medicine, but about becoming a better person overall. Are you able to balance your family, your friends, and other things like that? So, sorry, I know I'm doing a lot of rambling, but there's lots of different questions. And so just trying to touch on each one. Nicola, do you think we want to switch to cases real quick and then?
Yeah, we can do that. That works. And then we can get back to questions at the end.
Okay, perfect. So I will share my screen at this time. Okay, can you all see this?
Yep.
Awesome. All right, you guys can still see it though, right?
Mm-hmm.
Okay, cool. So because sports medicine, right? So I'm very interested in it. There's just a couple cases. They're both about knee pain, but they're very different from each other. Just to get you guys to think about, different things that we'll see in clinic. These are very simple cases, but I think it gives you a representation of, it's not always just a fracture or, tearing an ACL. There's a lot more to things. You need to have a wide differential and you need to have a thorough physical exam and a history. So I will try, I hope I don't, because there's people from all different levels here, hopefully we can keep everyone on board. So I'll read the first case. A 30-year-old male runner presents to the clinic with right knee pain. He started jogging about 2 months ago to lose weight and has progressively increased the intensity and duration of his jogs/runs. He runs 2 to 3 miles 5 days out of the week. The pain is in the lateral aspect of his knee and is achy in nature. It's worse with running. Resting makes it better. He's tried icing it, but it hasn't helped much. He takes over-the-counter Tylenol. This partially helps. He stretches after his runs, but the pain is still there the next day. He bought a knee brace from CVS, but this has not helped and is uncomfortable when he runs. He denies any trauma, falls, accidents, or previous injury to the knee. All right, so just a summary. We have a runner. It's in the lateral aspect of his knee. It's achy. Resting makes it better. Tylenol barely helps. Brace didn't help. Stretching doesn't help very much either. I am sorry for my messages. All right, so physical exam. We're just going to go through a general physical exam, and then I will mention this runner's physical exam afterwards, only the pertinent positives. So anytime you want to do a musculoskeletal exam, any joint that you evaluate in the body, you want to do it in this order because you want to do it in the same order, and because you don't want to miss anything. And when you present to your attending, you're going to look like an all-star. And so first you want to inspect, just look at them. How does the knee look? What is its structure? Is there swelling? Is there erythema or redness? Also part of inspection is gait analysis. Just have them walk up and down the halls and see, how are their hips? How are their shoulders? How are their knees and ankles? Are they limping? If so, what side? Things like that. Then you want to do palpation. Then you want to actually touch the patient. You want to palpate along the joint line, and I'll show you in a picture after in a couple slides. You want to palpate all the soft tissue structures, such as all the muscles, the tendons, the ligaments. You want to translate the patella, and again, this is just specific to the knee, but you would do the respective physical exam of whichever joint that you're evaluating. You want to milk the joint, basically just to check if there's any fluid that's collecting in there, even if you don't see it grossly on inspection. Then you want to do range of motion. You want to do passive range of motion first, or you can do passive or active. Different providers do it differently. Well, passive range of motion is that I am moving the knee for the patient. So the patient is not doing any effort. Active range of motion is the patient is actively moving the knee for me, so I can see what they can do. Then you want to assess neurovascular status, right? So even though this is a musculoskeletal complaint, we need to do a proper neurology exam. So you want to check, and vascular exam, of course. So pulses, pedal pulses, and then you want to strength test. You want to check all the, bilaterally. Always start with the good leg and then go to the bad leg. And then you want to test their sensory. The sensory exam, you can do light touch, but again, that's not very accurate. And then reflexes, so patellar reflex and Achilles reflex. Then you want to go to special tests. And for the knee, there's all of these. I'm not going to go through all of these just because I think it's going to be too much detail, but you have it. We're going to talk about two of them that's going to be important for this case. And then remember, you always want to check the joint proximal and distal. So if they're complaining of knee pain, you're checking their hip and you're checking their ankle, because the body is connected. One issue in one area can drive up the chain and cause issues in another area. So what are the positives from our runner? He has tenderness upon palpation of the lateral hip. He has 4 out of 5 right leg abduction. So when you're doing muscle strength testing and you have the person, move their leg kind of to the side, away from their body, it's not very strong. 5 out of 5 is the strongest. 4 out of 5 is just a little weaker. You can break them. They should be able to break you, but if you can break them, that's a 4 out of 5. And it's secondary to pain. It's because it hurts. It's not just because they're weak. And then a positive Auber's test. So what is the Aubert test? You're lying on your side. Can you see my cursor?
Yeah.
Okay. So you're lying on your side, and let's say this is the knee or the leg that we want to evaluate. We will have them extend their leg back. Now, do you see how his leg, when it's in neutral position, should be in a straight line? But then when he extends it back behind him, the angle increases. And it should be flat like this. But the reason it increases like this is because there's an issue right here in the hip. And remember, on the previous side, we had tenderness upon palpation of the lateral hip. So even though he's coming for knee pain, now we're starting to think, what's going on in the lateral aspect of the hip here? Then there's the Thomas test. This test you can use for this diagnosis, or you can use for a tight quadriceps tendon. Now in this one, you're assessing the bottom leg. So they hug this leg. If the bottom leg is right now is flat, if it was elevated, that means they have a tight quadriceps muscle. And so you would have to relax that. Or in this case, you can't see it because it's from the side. Their leg would kind of go behind, towards the screen. If you can kind of imagine that, it would be pulled to the side. So what are we thinking here? What is our differential? This is a screenshot from one of the conferences that we had. It's an advantage of going to conferences. Always try to do that as medical students. If you can get into conferences first and second year, you will make lots of connections. You will be inspired about, from different people. So what aspect of the knee? The joint line is right here. You want to palpate throughout the entire joint line over here around the patella. You want to move the patella in all different directions. But for this one, so this is the medial side, the middle, this is the lateral side. So they are having lateral knee pain. So if we look here, pain here can mean what? Iliotibial band syndrome or IT band syndrome, or it could be what if it was down here? It could be a meniscus tear, a ligament tear, like an ACL or MCL tear, or it could be arthritis of the knee. But again, this is a young guy. He probably doesn't have arthritis. He doesn't have any injury. He didn't fall, get in a car accident, things like that. And so it's probably not a meniscus or ligament tear. So I wouldn't jump to imaging. I would not get an x-ray on this one. So now we're thinking, maybe is it IT band syndrome? So let's talk about that. The IT band is a band of it's not a muscle. The muscle is actually called the Tensor Fascia Lata. This is that muscle right here. This is just a tendon. It's a band of connective tissue. It is not a muscle, so it does not actually do any work. It just helps hold the leg together. The muscle in front of it, the TFL, is going to kind of merge into the IT band, and the IT band connects right here on the lateral aspect of the knee. And so when this muscle right here, the tensor fascia lata, is tight, you can imagine that it can pull on this area and cause pain every time. IT band syndrome is when this band itself is tight. When you're, for people who run a lot, people who sit at a computer all day and, their hips are kind of flexed in a position, their IT band just contracts a little bit. Not like a muscle, but just, the tissue becomes tight. And then when you try to run, you try to, it doesn't release, it can cause pain. Especially, it can cause pain over here at the hip or down here at the knee. But a tight tensor fascia lata is something that is missed on so many people. A lot of people will say, even if this happens in older people, you have to say that it can't just be arthritis. They don't always need a knee replacement. You have to check this area. You have to get them into physical therapy and things like that to help them. If it doesn't work, then we can jump to surgery. Surgery is always last line. So what would our plan be for this guy? I would first of all switch Tylenol to Motrin as needed. Tylenol's acetaminophen, Motrin is ibuprofen. Ibuprofen has anti-inflammatory properties. So we want to decrease that inflammation from the tendon pulling on the bone. I want to refer to physical therapy, or I could give them home stretches for the tensor fascia lata and IT band, whatever they prefer. I can do OMT, again, another tool in the toolbox I can use. There's a lot of cool techniques. And again, we don't have time to go through all of them. There's very soft techniques like myofascial release, where the patient isn't really doing much. They're just taking deep breaths. There's muscle energy, where I help the patient kind of give resistance against my hand. There's counter strain, where again, it's a fold and hold technique. So I would shorten that muscle passively and hold it there for 90 seconds. There's balanced ligamentous tension. There's other techniques that we can use, but there's so many different things. It's very different from going to the chiropractor. This is very individualized, and many chiropractors may do that, but we can do thrusts, high velocity, low amplitude techniques. That's one of the things that we learn, but we learn a lot of these calm techniques, which actually are for most people. Not everyone can handle high velocity and thrusting techniques, especially when they're not individualized. We go to the exact level. If I'm treating their back, I go to the exact level, like let's say T4. What position is T4 in? It's rotated, side bent, and flexed. I make that diagnosis and I treat that specific thing. So OMT is very, very different from different therapies like that. And obviously, as you can tell, it's very different from just blind massage therapy as well. I would discontinue that knee brace. Knee brace, if you wear it for too long, it can cause the brace is doing the supporting. So then your muscles aren't doing any supporting. So then when you start running, your muscles are weaker. That can lead to injury. And plus, it's not helping him. And then other counseling on other weight loss techniques. Losing 1 pound of weight takes off 3 to 5 pounds of pressure on each knee. Just think about that. Every step that you take, if you lose 10 pounds, you're taking 30 to 50 pounds of force off of each knee every step you take. That's going to be better pain control than any medication that you can give them or any surgery. And again, weight loss is difficult, but there's so many things that we can do. We can refer to weight loss clinics, lifestyle changes for sure. Even if they can't run, they can swim. Swimming is a great exercise for this person if they're trying to lose weight, but they can't run. So hopefully that helps. And so this is just a quick video.
Over thumb technique here. And then you'll notice I have...
He's not doing the techniques that I said, but just to give you some idea of how I just got this from YouTube. I can just skip through it a little bit. He's doing passive techniques, just more relaxing the muscle. A lot of the OMT that I do is the art of relaxing muscles, because we all sit in positions that we shouldn't sit in, do things that we shouldn't do. And so a lot of times, even when it looks like we're not doing much, he's adding pressure. She's probably breathing. You can add other enhancers like pushing the knee into the ground. And again, I couldn't find a perfect video for this, so this might be a bad example. But now he's doing more of a soft tissue technique. So there's lots of different things we can do. So I just wanted to kind of show you a snippet of that. Are we doing okay on cases? Do you want to do another one or leave it to question answer?
I think we can go through another one and then do question and answers.
Okay, cool. Do you want me to slow down, go into more
Oh, this is
detail?
perfect. Yeah, this is perfect.
Are you sure? Okay, cool. So this is the second case. I only have two cases, but so now that you guys kind of have the physical exam, are familiar more with how to think through the case, let's try the second one. 50-year-old male presenting to the clinic, 6 weeks of left knee pain. He has never felt this before. There's no inciting event or injury. He gradually developed medial knee pain, which is worse when he walks around his work facility. Daily average step count is 10,000 steps. His knee aches at the end of the day. Of note, he has also recently developed low back pain on the left side as well. He has tried Motrin, which helps partially, but doesn't want to take so many pills throughout the day. He bought a back brace, but this has not helped either. So it's cool. I mean, he's tried a few things already. It hasn't helped. He is on an anti-inflammatory, but again, how much is he taking? Is he just taking one over-the-counter Motrin a day, or is he taking more? We don't know. So that I would ask him more about that. I would ask him, when is he wearing his back brace? I would ask him, are you doing any lifting? A lot of people this summer that I've seen in clinic, they're gardening and they love gardening. And so they're like, Doc, my back hurts, but I'm still going to continue gardening. Well, I was like, well, thanks for the honesty, but you're making my job a little harder because you know what's causing the issue. But no, that's okay. We have to work with patients, right? We want to help them live the quality of life that they want to live. We want to help them to do the things that they like to do. And for a sports medicine doctor, that's exactly what it is. These people are playing professional sports at, whether it's high school, college, or, the NBA, NFL, that level, or even the Olympics, that are happening right now. We have to help them in whatever way that we can to help them achieve the goals that they want to achieve. So the more tools that we have in our toolbox, the better doctor we will be. So this person's physical exam, there's mild swelling of the right, this says right knee, but it should be left knee upon inspection and the milking test. There's tenderness upon palpation of the medial knee and the medial malleolus. And we'll talk about that in a little bit. And remember, we want to check the back, right? Because they were complaining of the back, but we also want to check the hips and the ankles. And so let's look at the gait analysis when we are checking that. Here's a video. This person I know is running on a treadmill. It's just the best thing I could find, but when you're analyzing a gait, this is one of the first things that we did in OMT class. I remember because I volunteered, or people volunteered for me for this. The whole class is staring at you and you're walking. And it's very awkward because that was the day I was told that I'm not walking properly. And that's kind of embarrassing when you've been walking your entire life. But we all have some imperfections in our gait. So see if you can figure out, oh, why did that happen? See if you can figure out what's wrong when you're seeing this. And again, you'll see this when they're walking as well. You see that you can see their toes pointed out a little bit. See, just like that angle. And so it should be a straight line, right? But you see that. And where the stress is going to be now, instead of being neutral in a straight line up and down, the stress is, there's the answer, but the stress is happening right here in the medial aspect of that ankle. And so that's why they're presenting, and also in the medial aspect of the knee. And so this is something that's very concerning because it's causing them knee pain. This might hurt a little bit, but really the knee, and if I could show you, I think I have a picture right here. Yeah, this is what's happening. This person has an overpronation problem. Podiatrists are really good at solving this, and thankfully I actually did a podiatry rotation as part of my residency, which is where I learned about this. So they're in pronating their foot or inverting their foot, which is causing stress over here. But then as you can see, instead of their leg being straight, it's going like this. I'm exaggerating, but this is the angle it's making. And so they're going to get medial joint knee pain right here. Now, how do we fix this, right? And why are they getting back pain? Remember when we said the whole body's connected, it's a whole chain. If it starts here, it's going to cause this issue, which is going to cause medial stress on the knee. Medial stress on the knee causes lateral stress on the hip. Lateral stress on the hip will tilt your pelvis. It's going to contract your psoas. It's going to cause thoracic lumbar pain. The psoas will connect to the lumbar, vertebrae. You're going to have lordosis. That's going to cause everything up. And, if you're thinking, oh, that would never happen, people with this issue will complain of pain all over. And even if they're not complaining of pain at that time, if this keeps happening, that pain just rides up and up and up. And even if you palpate their back muscles will be hard as a rock. And they'll be like, yeah, doc, I can't even exercise. It's not hurting, but it's just so hard because I feel so stiff. And so this does happen. And again, this is the way that, in osteopathic medical school, these are the things that we really learn about this whole kinetic chain. So knee pain is actually a mechanics issue in how they're walking. So overpronation of the foot, what I would do a few things. One, I would give them insoles that are supportive. The Power Step is really cool. The Power Step Pinnacle. I actually wear these, not the max support, a different one, but that's something that a lot of people can actually throw into any kind of shoe, and it can be good for anyone if they have a gait issue or not. What else I would do is I would recommend them a stability shoe. They need a stability shoe because their foot cannot be straight on its own. So we're going to need to give them a sturdy shoe to throw them back in line so that their foot doesn't drop over here in this medial aspect. So what is a stability shoe? Well, there's 3 tests that you want to do. And again, you can't do this online unless they market it as a stability shoe. So I would go into Running Fit and buy a stability shoe. These are the 4 companies that make really, really good shoes. These are the ones that we usually recommend. There are stability shoes that, Nike, Adidas, and other companies make. But again, most of their shoes are more just for, they're for fashion. And even a lot of times they'll advertise it as being good, but it's not a true stability shoe. So what's a stability shoe? You're going to do 3 tests. You're going to wring the shoe out. You're going to hold it in your hands, one hand on each side, one hand at the heel, one hand at the toes, and you're going to wring it out like a towel in a twisting motion. If it rolls very easily, that's not going to give you much support, but you don't want it very rigid either. Most of the time, you're not even going to find shoes in motion control. It's either going to be neutral or stability. So you want it to be a little bit more rigid. It should still have some give, but this should not happen. This is, again, the twisting. Sorry, this is the one I was talking about, the twisting, wringing it out like a towel. This one is just scrunching it up. So if your hand is here and here, you're scrunching it. Sorry. You're scrunching it up, and you want to see this is not acceptable. A stability shoe will only bend from the toes. It won't bend from the middle part of the shoe. And the last thing, you want to kind of compress the heel cup to see how much heel control, because pronation starts with the heel. If you can get the heel in line, your whole foot will be in line. And so I would tell them, I want you to buy a stability shoe. I want you to use these insoles. I know it's the summer and you want to wear your flip-flops and your sandals, but the more you wear them, it's going to hurt even more. I would prescribe Voltaren gel. Voltaren gel is basically Motrin in gel form. So you don't have systemic absorption. It's just in that area. And because it's not an issue with inside the knee itself, this would be a really good thing that they apply in the medial aspect of the knee. If they really wanted, they were complaining that, oh, doc, I don't want to take Motrin all the time, I would prescribe Mobic. Mobic is a cousin of ibuprofen or Motrin, but it's really good for musculoskeletal pain, and it's longer acting. So it's 7.5 or 15 milligrams just once a day. You take that with food, and it's studies have shown it can help you a lot better in terms of back pain as well. And then I would, of course, give them stretches. Lifestyle changes should always be part of their homework, because I'm doing my part as a doctor to get, to diagnose them and get them in the right direction. But then the patient has to do their job to maintain that state of health. And that goes for anything, whether it's hypertension, diabetes, weight loss, any medical condition. Other tools in MSK, we already talked about some of them. Activity modification is really big. A lot of times you can't tell them, hey, stop playing the sport that's causing your injury. You got to work with them and say, how can I modify some of the things that you do so that you can continue playing that sport? You want to give them a home exercise program or refer them to an athletic trainer if you don't know the right exercises. They don't need to always meet with them, and they don't have to be an athlete to go to an athletic trainer. Older people can do that as well. And just 1 or 2 visits can really help them get a good home regimen going. Ice usually is better for heat when it comes to these kinds of things, just for decreasing inflammation. Using braces and even splinting, of course, if there was a fracture, if there was a tear, things like that. You can also use other gels. We talked about Voltaren gel. Voltaren is that Motrin cousin. Biofreeze, Bengay, and Icy Hot are just more of topical anesthetics. So it's not going to help decrease inflammation. It's just pain relief. That can help too. There's other alternative treatments such as acupuncture and CBD oil. There are, people, this is more data from just people saying that it works. The data really isn't out yet, but the side effects of both of these are very low. And so, hey, if it's going to help you, do it. It's going to be better than any medication I give you. If it's not in terms of side effects. Muscle relaxers can also work for a lot of people. These are construction workers who work at Amazon or delivering packages all day, things like that. They have very, very tight muscles because they're doing these repetitive movements for a long time. These are, 3 different muscle relaxers. These, can make you sleepy. This one won't. You talk to them about that. You can do short-term oral steroids. Again, you don't do this very often. This is only for very, very severe disease. You can do trigger point and joint injections, steroid injections, something that, I really want to do. These can be ultrasound guided. Ultrasound guided injections are a lot more accurate and more effective, the studies have shown, than just going in blind and just using palpation. There's also epidural and facet injections for the back. These are under X-ray guidance. Some people even do them under ultrasound guidance. But this is for more radiculopathy, so nerve impingement, slipped discs in the back, things like that. You want to avoid opioids. The government is cracking down hard on people with opioids. We want to try to wean them off. Opioids are just not a great medication. There are a subset of people who need them, people who have severe disease. And when they're used in very low doses in moderation, it's okay, but it's a slippery slope due to their addiction potential. And then, of course, surgery is last resort. And so I think that's it. I know I went really quickly through that. Hopefully you guys were able to keep up or get something out of that presentation. But I guess I'll stop talking and just see where you guys are at right now.
Yeah, so we do.
I cannot hear you. I think you're cutting off.
A few minutes left. If you want to answer more questions, that would be great. Post.
Okay.
Can you hear me?
Yeah, I can hear you now. Sorry. Okay, answer a few more questions is what I heard.
Yeah, and then I'm just gonna post the Google form for everyone else, and then just make sure you submit that by 9 p.m. But yeah, you can go ahead and answer a few more questions by in the next few minutes. Yep.
Okay, cool. So as you guys see, I'm very passionate about MSK and sports medicine. I love it. It really makes you, it's not just as simple as it is, right? Both of those cases were knee pain, but the issue wasn't the knee in either of them. And so you have to look, and it's very easy to say, oh yeah, that's easy now. But when the patient's telling you the story and they're like, doc, it's my knee, I need x-rays. It's like, no, you don't need x-rays. You don't need, injections yet. There's a lot of other things that we can do. We can work together. So it's about giving the best treatment, not just what, the patient's coming in for. So I think that's, There's a question here of just challenges I face and the most exciting day. I mean, challenges are just all throughout, you know. I mean, exams are the biggest. It's everything is high stakes. You know, you fail something, you're risking fail. If a class only has 3 exams and you fail one of them, you fail the whole class. You fail the class, you fail the whole year. So, you know, it's very high stakes. And I wasn't the greatest at exams, even standardized exams. I wasn't good. I still am not the greatest, but you get better. You know, you don't have to be a genius to become a doctor. You have to work hard, and that's all people want. You have to be curious. You have to be proactive in your learning. You're gonna want you have to show that I'm here to learn, and it's okay if you don't know anything, right? No one can know everything, but it's going to go much further if you show that enthusiasm and that drive. And so that's going to be the most that's going to get you through the challenges. Having a good support system, you know, being close to family, friends, having food made for you at home. I'm spoiled, but again, those things help you face those challenges. You know, exciting time, I guess. Knowing that you're matched into a residency was super exciting. Knowing that you're starting third year of rotations and you're past step one was super exciting. Just because the first 2 years you're in a classroom, you know, and it's just exams, more material, and you don't get to relate it to real patients. So when that happens and you start seeing everything in place third and fourth year, you know, I say that medical school is only 2 years. It's the first 2 years. After that, you know, your work, yeah, you're taking your exams once a month, you're still studying, but it's so much more fulfilling, you know. So if you can get through just 2 years after undergrad, you should you know, don't think that, oh, it's so long. You know, people are always saying, oh, I'm going to wait for the light at the end of the tunnel, or I see the light at the end of the tunnel. But why can't we see the light inside the tunnel, you know? And I know that's like a cliche thing to say, but like you want to be happy when you go through this journey. You don't want to suffer through the whole thing and then look back, it's like, wow, med school was miserable. It was hard. But it was challenging, but you want to remember it as a good time, as a time where you grew, you became a better person. And so I think when you really reframe and have a positive attitude and positive outlook on just everything in life, whether that's med school or anything else, I think it'll go much further. So that's what I would say. COVID has not impacted me too much. The last semester of medical school, we didn't have rotations. When I started residency, there were still some waves of COVID, but it's been so much better now. Hopefully, this variant doesn't screw us over going into the fall and winter. People with vaccines are doing so much better than those who haven't gotten their vaccines. I think just from a purely health and medical perspective, I mean, we've seen that. I think it's one of the greatest things that humanity has done in this century. So definitely consider it. I totally understand when people have concerns about, you know, getting the vaccine because it came out so quickly. You hear these side effects and different things like that, but you know, just talk to your doctor, talk to trustworthy resources, have an open mind, read, you know, CDC, WHO, like reputable websites, in addition to the other ones that you want to read too. But I think we'll be able to get through this, and it'll be a fun time.
All right, sounds good. So I think that's it for the questions. Thank you so much for joining us today. This was a very informative virtual shadowing session. I definitely learned a lot, and it was really nice to meet someone that also went to MSU Com. So thanks again for joining us. And then for everyone else, just make sure you fill out that Google form. It should be in the chat. So that's about it. Thank you so much.
Yeah, no problem. Great to be here. If you guys have any other questions, feel free to reach out. Instagram's probably just the best way. It's just at Dr. Venida. So if you guys have any issues, I think it was on your Instagram too. So just reach out. That's probably the quickest way for me to get back to you. Yeah, good luck on everyone's, you know, journeys. And if you ever need anything, we're always here for you.
All right. Thank you so much.
Yep. Take care.